Now to the exercise prescription. So the overall objectives for our prescription is to regain and improve functioning, which means aerobic capacity, strength and flexibility. We want to improve their body image and quality of life, and part of this is through developing confidence in their body again, through improving their capacity. We want to improve their body composition, which will reduce their cardiovascular risk. Potentially we may reduce or delay their recurrence by making them more physically active. Certainly if they're inactive, then their reduce of recurrence is increased. We want to reduce and prevent long-term and late side effects, and if they need to undergo future treatments for a recurrent cancer, then we want to give them improved capacity, which means they'll be able to handle those treatments better in the future. The goals will obviously vary depending on the individual though. So essentially the ACSM guidelines tell us that we need to avoid inactivity. So even in cancer patients with existing disease or those who are undergoing difficult treatments, should be recommended that they participate in exercise. Supervised, well, that's much better if it can be. If they're not able to meet the guidelines, they should be as physically active as their abilities and their conditions allow. We need to individualise these programs to take into account their health status, what treatments they've received or receiving, and their anticipated disease trajectory. So for someone who has an early stage cancer, it's likely that they're going to they're going to live a lot longer. We're going to treat them differently to someone who has pancreatic cancer, for example. We've got different goals for those people. So this is essentially the guidelines, and if this looks familiar to other guidelines, then you'd be right. This is basically the normal healthy population guidelines: 150 minutes a week of moderate or 75 minutes a week of vigorous intensity aerobic activity. Resistance training, 10 to 15 RM, so this is moderate resistance training, major muscle groups 2 to 3 times a week, and flexibility, so stretching major muscle groups and tendons. Obviously flexibility is not quite as important as the other types of training, but in certain circumstances like post-surgery, stretching does become very important because the scar tissue may limit their range of motion, which we might need to restore. If we're going to be doing testing, if we're going to prescribe exercise, we're going to be doing testing. Everything we test, everything we measure must be relevant to the improvement of the cancer survivors' outcomes. We don't want to be wasting their time or risking recurrence of fatigue because we're testing everything under the sun. We need to test what's relevant. What do we need to know to improve their condition, and what do we need to know to prescribe? All procedures obviously should be valid and reliable. We need to have consistent protocols. We need to protect their rights. That's their right to refuse. Also their right to privacy. We don't want to be calling them up at home, leaving messages on their home voicemail saying, we're from the ACU Cancer Survivor Exercise Group or whatever it is, because they may have chosen not to tell certain people in their family. Testing should be repeated at regular intervals. We need to review and discuss with the patient what their results mean and report to the referring doctor. We use the test information, as we do with all populations, to inform the exercise prescription. Some cancer-specific contraindications to exercise testing. Obviously all the standard contraindications apply in terms of uncontrolled hypertension, angina and all the rest of it. But cancer-specific, there are some relative and absolute contraindications outlined by ACSM, which you can get your hands on. We should be monitoring heart rate, blood pressure and breathing frequency. Monitoring RPE. We should be aware that if they've got more advanced cancer or distal metastases, especially of the bone, then we need to be aware that they're going to have compromised skeletal integrity, which makes some tests inappropriate. So if they've got, for example, lumbar spine metastases or reduced lumbar spine bone density as a result of hormone treatment, for example, then a test where we're timing how many times they can or how quickly they can rise from a chair and sit back down again, that might not be the best test for them, because if they land heavily sitting down into a chair, that could cause problems in their lumbar spine. We also need to take into account that time of day might affect fatigue and other symptoms. Now, cancer-related fatigue is going to complicate our exercise prescription a little bit. And generally, if we're prescribing exercise or making recommendations for people for weight loss, we're going to tell them that they're going to do our supervised exercise and then try and be as active as possible throughout the day. Things like taking the stairs instead of the escalator, parking further away from the shops so they walk part of the way. If they've got cancer-related fatigue, this is one major difference with our exercise prescription. We want them to be able to come in and do our moderate to high intensity supervised exercise, but to do that they might need to be resting more throughout the rest of the day. So having them climb stairs, walk with their shopping, walk the dog, all these other sort of strategies that we might employ to keep other people more active might actually mean that they're too fatigued to come and do your supervised exercise session. So in this case, with cancer-related fatigue, we don't recommend those extra bits. We want them to come and do the targeted prescribed exercise. What assessments you do is going to depend on the individual. You're certainly going to do a health history questionnaire, record their height and weight and probably waist circumference, resting heart rate and blood pressures, and other tests are going to depend on the person. So if they're lung cancer, you might have to do pulse oximetry and look at pulmonary function. If they've got other toxicities of treatment, we might need to look at their balance. Do we need to look at their blood profile? There are certain blood markers in terms of iron levels, white cell count, and other things that we need to check before they exercise that are cancer specific. Body composition and bone density might be something that you have access to be able to measure that might be important for these patients. And measuring fatigue, might measure fatigue before and after every exercise session, for example. So we need to ask ourselves, is the parameter that we want to test required, or is it important to the patient's goals or the intended training program? Does the client report issues or problems with that parameter? And is the information required for the exercise prescription? So we need to be able to answer these questions to be able to really determine if what we're doing is appropriate. The assessment needs to fit the activity, and the test needs to fit the program and the ability of the client. So here's a nice little summary here talking about the role of exercise in cancer, the benefits of increasing activity, and how it addresses the different side effects. Obviously, this is a bit of a snapshot in cancer that's appropriate for the undergrad level. Exercise physiology content goes into much more detail about exactly how we would prescribe for different types of cancers and different types of treatment side effects.